So the myth that Americans don't like managed care is exploded by the actual experience, which is not only here but in Wisconsin and some other places, if they're given the choice and the opportunity to keep the savings, that's what they choose. But on the other hand, some large high-tech employers, who will remain nameless because they were kind enough to talk to me, stick to the self-insured fee-for-service model. When I asked them why do they do that, they emphasized the war for talent. You know, we have this complicated business, we need really excellent people, and so we want to make our benefits so generous that they're the most generous. And so if they do offer any choices, they pay 90 or 100% of whatever the employee chooses. They value the ERISA preemption from costly state regulation with its mandated benefits, something for which I don't think any reasonable person could blame them. They apparently are not impressed by the potential of integrated delivery systems, which I think gives us some more work to do to explain that. But you can see that this is not a model that's compatible with healthcare financing and delivery systems competing on value for money, because the customers who are making the choice are not cost conscious. So I think it's a big problem when we have open-ended self-insured fee-for-service employers, because I think they're helping to destroy competition for the rest of it. Let me explain that with an example that's going on in California now. We have two kinds of HMO in California. One, delivery system HMO, the main one being Kaiser Permanente, where the chassis is a delivery system, and then what I call carrier HMOs, the Blues, Cigna, some others, who contract with some medical groups, in fact about 200 medical groups and IPAs up and down the state, on a per capita prepayment basis for the physician services. Now, these groups then work for HMOs on a per capita prepayment basis, but they also have a lot of business working for PPOs on an uncontrolled fee-for-service basis. Well, being in an HMO is an awful lot more work for a provider. There's quality reporting, quality management, utilization management, and so forth. Fee-for-service, on the other hand, with a PPO is a lot easier and probably better paid. So now you have these medical groups, let's say with a substantial part in fee-for-service and a substantial part in the HMO. When they thought that there would be real competition, I think a lot of them signed up for the HMOs, figuring, you know, if we don't get with that, when, say, the employers and the government make us really compete on value, then Kaiser's going to eat our lunch. So we'd better start getting ready for that. But I'm afraid what's happening now is the employers and the government are not making them compete, and there's a drift in the wrong direction. And in fact, University of California people told me something that I've started observing at Stanford, and that is that our carrier HMOs fees or costs are drifting up to approximate the PPOs. And at the Integrated Healthcare Association, we had a presentation with one major carrier showing that was happening. So at Stanford now, for example, for this coming year, for a family for the whole year, it's $16,600 in round numbers if they choose Kaiser Permanente. With HealthNet, it's $20,300. With Pacific Care, based on the Palo Alto Clinic, it's more than $21,000, and the PPO is about $21,300. So it looks to me like they aren't really competing with Kaiser anymore. Why? Because all their providers figure, well, we can really make it on fee-for-service. We don't have to put up, with all this. So the open-ended fee-for-service end of the demand side is wrecking it for those of us who would like to have some competition. Well, we can't contain their costs unless their docs are convinced that they have to compete and contain costs or lose their business. I'm afraid in a few more years, the non-Kaiser HMOs are going to be just like PPOs in their costs. And then I hate to think of what that does to my friends at Kaiser, which is it makes it a lot harder to motivate the troops to contain the costs and improve value. I mean, I used to run a business before I became a professor, and that's what I found. One of my companies was in a nice little oligopoly and didn't have to work very hard. Nobody wanted to listen to my exhortations for quality improvement. In another place, though, they were in very tough competition, and there, believe me, it was bare light bulbs and hard work, and you know, the whole company responds to the incentives. So I think that's a problem that's going on now. Another that's really interesting is we've talked about exchanges. We have probably the prototype or the mother of all exchanges here in California. It's called CalPERS. I'm not referring now to their investment side, which I prefer to ignore, but they are a monument in healthcare because they operate a large exchange which buys healthcare for brokers, if you like, for 1.3 million people. And they offer now 3 different PPOs that are self-insured, administered by Blue Cross. The reason for 3 is they started with 1, and then as its costs started going into a death spiral, they decided to introduce another one by having a much tighter network. So in effect, just having the higher value. They had a big shootout with Sutter Hospitals, our profitable nonprofit hospital system here, and I'm sure that they managed then to have a network that didn't include a lot of Sutter. And then yet a new select PPO, so with tighter networks. On the HMO side, they offer 3 HMOs, Kaiser Permanente, which takes care of about 1/3 of all their people, Blue Shield Access Plus, which is one that markets all 200 of the medical groups and IPAs, and now again following the same pattern, Blue Shield Net Value, which is a much tighter network of higher value provider groups. PERS used to offer uniform prices across the state. Then a funny thing happened as we went to the marketplace, which is Northern California became a whole lot more expensive than Southern California. So in Southern California, the local government agencies, by the way, I should have mentioned if I didn't, they broker health care for about 1,000 local government agencies. Well, local government agencies in the South were saying, hey, we could do better outside of CalPERS. Somebody else is coming to us with lower prices that reflect the local market. So, okay, so PERS had to price regionally. Then I think the most important innovation that has brought on is that Hill Physicians, a very well managed IPA which works in East Bay and Sacramento, has teamed up with Catholic Healthcare West, our other leading nonprofit hospital system, with managers in both cases who have long believed that integration of doctors and hospitals was an essential part of health reform, to offer in Sacramento the 2010 premium would be no higher than 2009 premium, absorbing about an 8 or 10% increase in improving efficiency. If then Blue Shield would pass that on to the customers in the form of a lower price. And so they do have a competitive price up there. That wouldn't have happened if you didn't have the combination of an exchange that can offer a large number of people so you can get enough people taking this product, cost-conscious consumers, as the state employees are, and doctors in Hill Physicians and hospitals in Catholic Healthcare West that understand and believe in integration as the way to improve value. And another thing you need is a competitor like Kaiser who looms there ready to eat their lunch if they don't shape up. So this is all to say, if you look at it carefully, we have some solid experiences to suggest that competition can and will drive innovation in the improvement of value for money. Thank you.